Good afternoon, students. In this lecture, we are going to learn about complex method of orthodontic treatment. Well, not always a patient with an anomaly of the dental-alveolar system can be cured by one method. Severity of orthodontic cases is the indication for a complex method using. The use of a complex method allows to minimize the total treatment time through the surgery of the tongue frenulum, speech therapy, myotherapy, the use of compact osteotomy, and subsequent instrumental treatment according to indications in combination with the extraction of individual teeth. These photos illustrate the complex treatment a patient with class 3 skeletal malocclusion. Doctors used orthodontic surgery and final orthopedic methods of treatment and got excellent results. Methods of treatment of dental-alveolar anomalies can be divided into 5 main types: myotherapy, instrumental treatment or orthodontic method, complex treatment. It is combination of several methods of treatment, then surgical and orthopedic treatment. Every type of dental-alveolar anomaly treatment can be used as a primary or additional method of treatment depending on the age, the period of occlusion, the degree of pathology severity. Treatment of dentofacial disorders must be started early in childhood while bones grow. Mostly, myotherapy is the first ortho treatment child has to get to prevent more severe malocclusion. Myotherapy is a method of prevention and treatment of dental-alveolar anomalies consisting of long and systematic exercises of malfunctioning groups of masticatory facial muscles, muscles of the tongue, and the bottom of the oral cavity. Myotherapy is the main method of treatment in the period of temporary occlusion if there are functional disorders and minor deviation in dental occlusion. It can be perceived as an additional method in combination with instrumental or complex method if there are functional disorders in the period of mixed occlusion. Correction of the prevalent number of dental-alveolar anomalies is carried out by the instrumental method. Therefore, it can be considered the main one during periods of mixed and permanent occlusion. The complex method can be the main one with sharply expressed violations of the dental-alveolar system associated with anomalies in size and eruption of teeth during periods of mixed and permanent occlusion. The surgical method or orthodontic surgery is applied during formation of permanent occlusion or after 16 years when other methods cannot provide a positive result of treatment. Surgical treatment of dental-alveolar anomalies is a complex reconstructive jaw surgery which helps change size and position of jaws. The orthopedic method of treatment is the main one in all periods of occlusal formation if the application of this method allows to eliminate aesthetic, functional, and morphological disorders of the dental alveolar system. The choice of treatment method is strictly individual and depends on a large number of factors. The overall indications for the method would be determined depending on the period of occlusion formation and severity of its disorders. During the period of temporary occlusion, the main task of an orthodontist is to create optimal conditions for the growth and development of various parts of the dental alveolar system. This could be achieved by eliminating the cause of occlusion anomalies with preventive measures, in particular myotherapy. According to the indications, the corresponding orthodontic instrumental method are applied, which in the first place stimulate the growth of the underdeveloped areas of the alveolar process of the jaws. During the period of mixed occlusion, the treatment is mainly carried out by the instrumental method and rarely by the integrated method. Occlusion resolution could be achieved by moving teeth, correcting the shape of the dental arches, stimulating the growth of the underdeveloped, and restraining the growth of the overdeveloped parts of jaws. In this period, the orthodontic method of treatment is often combined with myotherapy to speed up treatment, consolidate its results. During the period of permanent occlusion, the possibilities of orthodontic treatment are considerably limited in comparison with the previous periods of its formation. In this period, it is already quite impossible to influence the growth of the dental alveolar system since it's basically completed. Therefore, with the help of instruments, the movement of teeth, the correction of shape and correlation of the dentition are carried out. In this period, a complex method of treatment is widely used, for example, combination of instrumental treatment with surgical interventions such as tooth extraction, compact osteotomy, plastic of shortened bridles of the upper or lower lips, and such like. At sharply expressed forms of open, distal and mesial occlusion formed due to growth and jaw disorders after completion of permanent occlusion formation, a surgical method of treatment is used. And now we will talk about the myotherapy in orthodontics. Exercises for the muscles surrounding the dentition have been used since the beginning of the 19th century, but as a method of orthodontic prophylaxis and treatment of dental alveolar anomalies was proposed by Rogers in 1917. In his opinion, germ and mimic muscles, also known as a regulator, are capable to eliminate started incorrect occlusion formation. He paid special attention to the position of lips and tongue, which has a major influence on the correct harmonious formation of the occlusion. The use of this method of treatment is most appropriate at the age between 4 and 7 years, when a child can understand what he is required to do and is able to perform exercises. The effect of treatment depends on the severity of morphological and functional disorders, as well as patient's perseverance and control over the thoroughness of the exercises. Parents, caregivers, or medical personnel are responsible for the control over the performance of exercises. The purpose of myotherapy is to change the functional state of the muscles of the maxillofacial area with the help of physical exercises. Tasks of myotherapy. First, restoration of the physiological tone of muscle tissue. Second, normalization of the muscles functions involved in the movements of lower jaw. Third, normalization of the function of the scapular muscles of the mouth and tone muscles. And next, adaptation of the tissues of the temporomandibular joints and muscles of the maxillofacial region to the orthodontic treatment instruments. Depending on the mode of muscular contraction, static and dynamic exercises are distinguished. With static exercises, muscles are in a state of increased tone without alternating periods of contraction and relaxation. Dynamic physical exercises are characterized by an isotonic mode of muscle contraction. The period of muscle contraction alternates with the period of its relaxation. Due to varying degrees of reduction of endurance, both static and dynamic are differentiated approach to the intensity of exercise is needed. Dynamic exercises are performed at a pace 20 minutes per minute or on the count of 1, 2, 3, 4. The starting position for performing static and dynamic exercises is standing or sitting on a chair in a state of correct posture. A head and body are kept straight, a chest is deployed. There are general rules for conducting myotherapy. Exercises should be done systematically and on a regular basis. The intensity of muscle contraction should be sufficient but not excessive. Muscles should be strained slowly and smoothly. Every exercise should be done several times until a feeling of easy fatigue. The number of exercises and their duration increase over time. When exercising with children from 4 to 7 years old, a simulator is used, which spring force should be around 0.7 to 0.8 kilograms for driven muscles and 0.15 kilograms for mimic muscles. The measure of physical activity on the maxillofacial area muscles depends on the age of a child and functional state of his muscles. Therefore, it is always individual and even between children of the same age. The intensity of performing muscle exercises can be different. To assign a load, a doctor needs to determine a degree of decrease in the functional state of the maxillofacial region muscles. For children with bite anomalies, there are 3 degrees of muscle endurance in the maxillofacial region. First degree: static and dynamic endurance of muscles is reduced by 25% in comparison with the age norm. Second degree: static static endurance reduced by 25%. For dynamic, the reduction is greater than 25% in comparison with the age norm. Degree 3: static and dynamic endurance is reduced by more than 25% in comparison with the age norm. The age norm for the performance of static and dynamic exercises is used by orthodontists to determine the degree of reduction in endurance of muscles in the maxillofacial region. The stopwatch determines the duration of the static and dynamic exercises. In accordance with the degree of endurance decrease, the intensity of each exercise is selected. When the first degree of endurance reduction, static and dynamic exercises are performed sequentially at a ratio of 1 to 1. Further intensity of exercises increases by half the value of the load. Second degree, static and dynamic exercises are performed at a ratio of 1 to 2. The intensity of static exercises increases by half the value of the load. Dynamic increases by. And first degree of muscle endurance reduction, the ratio of static and dynamic exercises is 1 to 1. The intensity of each exercise increases by a quarter of the load. In this case, the complex of exercises is repeated twice. While conducting medical gymnastics, you need to comply with basic pedagogical principles: visibility, accessibility, systematic gradualness. The method of organizing classes is individual or in group. A child performs exercises every day at home under the care of parents, and once every 2 weeks at clinic under the care of physician. During classes at the clinic, the child learns the exercises which are performed partly and completely. The method of visualization in the practice of therapeutic gymnastics should be present throughout the course of treatment and include the display and explanation of exercises, verbal instruction. The intensity of the exercise is adjusted in accordance to the degree of reduction in muscle endurance. That complies with one of the main principles of therapeutic gymnastics, the gradual increase in the load. The complex of therapeutic exercises consists of 3 parts: introductory, basic, and final. The introductory part includes briefing exercises for 2 or 3 minutes which prepare a child for the subsequent performance of therapeutic exercises. The main part of the complex focuses on training the muscles of the maxillofacial region and is performed in the certain sequence. Static exercises precede the dynamic, once as static efforts have a stimulating effect on dynamic work. The final part of medical gymnastics gradually reduces the overall and special loads, and this is achieved by combined exercises, various movements of hands and the head. In the course of training, attention is paid to observing nasal breathing and proper posture. Gymnastic exercises are prescribed without any devices or with special devices. These devices include the DASA activator, the equilibrator, the frail disc, Schonker vestibular plate, and the Marpe plates. So, exercises for the scapular muscles of the mouth. First exercise. Put a piece of a paper, hold it between your lips, and squeeze your lips when doing homework. Second exercise. You can hold the ruler with your lips, gradually loading it. Next, it is recommended to blow on the turntable, easily moving objects. Exercise with buttons. Two buttons with a diameter of 25 to 30 millimeters are connected by a cord and placed at a distance of 15-18 millimeters from each other. A child grabs one button with his lips and squeezes it. He holds the second button with the right hand, pulling the cord. The vestibular plate is inserted into the vestibule of the oral cavity. The plate is lightly pulled forward by the ring, while lips tighten and keep holding it. Next, oral disc is placed between the lips and held by them first for 1 minute, then for 3 to 5 minutes. A baby keeps activator dasa with lips. The force of contraction of the saccular muscle must overcome the force of contraction of the wire elements. This is static exercise. On the count of 1, 2, the child compresses his lips. On the count of 3, 4, squeezes and again repeats the exercise. It is a dynamic exercise. Next, maximum closure of the lips and the alternating closure of the lips. Exercises for a muscle of the anterior third of the tongue. A rubber ring with a diameter of 5 to 8 millimeters is placed on the tip of the tongue. A child lifts his tongue up and presses it to the front of the hard palate in the area of the palatine folds. His teeth clench, his lips do not close. It is recommended to swallow saliva without changing the position of the tip of the tongue and the rubber ring. If the tongue is between the dentition, then the exercise is not performed correctly. The patient presses the thumb rubber ring with the tip of the tongue toward the front of the palate in the area of the palatine folds. Teeth and lips compress, retaining the ring for 5 minutes. In the following days, the exercise time is increased to 10 minutes. Next exercise. Writing. Imitation of the sound of the horse hooves. Clinking of the tongue is performed 30-60 times. Exercise watch. With a half open mouth, the tongue is held on the upper and then on the lower lip from the side of the oral cavity, from left to right and vice versa. Next, stroking the hard and soft palate with the tongue along the middle line, starting from the front teeth. After mastering these exercises, they begin to train the muscles of the middle section of the tongue. Exercises for the muscles of the middle third of the tongue. First, two rubber rings are placed on the tongue, one on the tip, the other on the middle. The child lifts his tongue up and presses against the roof of the mouth, clenches his teeth. His lips do not close completely. Do not change the position of the tongue. Swallows the saliva 3 times. The tension of the masticatory muscles can be controlled by palpation, putting the fingers to the chest. If you swallow incorrectly, chewing muscles do not strain. Exercise for the muscles of the posterior third of the tongue. Rinse the throat with water, which helps to relax the muscles and massage them. Exercises for joint muscle training. First, maximum closure of dentitions, static exercises, squeezing the spring of Rogers shock absorber. The doctor set the nozzles between the dentition rows of the upper and lower jaws and slowly releases the spring. A child should close his mouth, pinch the dentitions as much as possible, and keep them in such a position for a set time specified by doctor. Second, alternate closure of the dentition. Dynamic exercise. The nozzles of the simulator are located between the dentition rows. On the count of 1, 2, a child raises and closes the dentition. On the count of 3, 4, he opens them and puts down the lower jaw. Then again repeats the exercise. Hold the lower jaw in the maximally extended position. A child maximally pushes forward or pushes back the lower jaw and keeps it in this position. Alternate protrusion of the lower jaw, dynamic exercise. A child pushes the lower jaw forward or back on the count of 1, 2. On the count of 3, 4, he moves the lower jaw into habitual position, then repeats the exercise again. Orthodontists use following surgical interventions in their practice: compact osteotomy, plastic surgery of upper lip frenulum, plastic surgery of lower lip frenulum and vestibulum of oral cavity, plastic surgery of tongue frenulum, surgical exposure of tooth crown, extraction of single tooth according to indications. Thus, in cases of severe dental-alveolar anomalies, for reducing the time of treatment and achieving sustainable results, compact osteotomy is indicated before using orthodontic appliances. Compact osteotomy is well known for a long time. To accelerate orthodontic treatment, with severe dentofacial anomalies, and also to obtain more stable results of treatment, preliminary surgical intervention, compact osteotomy, is indicated. Lindbergh pointed out that the main theme in this method is not mechanical weakening of bone tissue and arising in it in response to trauma biological reaction of inflammation. As a result of the compact osteotomy in bone, aseptic inflammation is observed, which is accompanied by the mineralization of bone tissue in the inflammation zone. Then reparative processes activate, which facilitates the restructuring of bone tissue under the impact of orthodontic devices. Titova developed method of latticed compact osteotomy. Operation is performed under local anesthesia in a polyclinic and consists of four stages. The first stage, sections of the mucosa and periosteum 4-5 mm in length on the vestibular surface of the alveolar process along or across interdental alveolar septum of displaced teeth at the level of the roots middle and from the palatine side retreating 4-5 mm from the gingival margin. Horizontal sections are indicated for the subsequent expansion of dental arch, vertical for dental-alveolar lengthening or shortening. Second stage, tunneling. With the help of narrow smoothing mini-spatula are tunneled under mucous membranes and periosteum up and down is done. The third stage is the introduction of the bear into a tunnel and disruption of the compact layer of bone. The fourth stage is the rapprochement of the edge of mucous membrane and periosteum, wound treatment. For expanding the upper dentition and the body movement of posterior teeth, compact osteotomy should be carried out with both from vestibular and the oral sides of the jaw. For teeth movement in vestibular direction or movement in the vertical plane, compact osteotomy is done from the vestibular side of the alveolar process and in the area of the root apex of displaced teeth. For the body movement of the anterior teeth and rotations along the vertical axis, both from the vestibular and the oral sides. For the distalization of teeth, compact osteotomy should be done in front of the behind the roots of displaced teeth. Mineralization of bone tissue appears by 20-14 days after surgery, thus in the period of the greatest destruction of bone tissue in the zone of compact osteotomy, the stage of strengthening of bone tissue. Orthodontic treatment should be started on the 20-30 day after the compact osteotomy. Combined application of compact osteotomy before instrumental method allows to shorten the treatment period of dental alveolar anomalies in 1.05 times. Depending on the severity of the dental-alveolar anomalies, orthodontic treatment after compact osteotomy lasts from 1 to 4 months. So, plastic of the shortened frenulum of the upper lip. The attachment of the frenulum of upper lip is one of the cases of diastema on the upper jaw. To clarify the indication for plastic of upper lip frenulum, X-ray examination of the alveolar process in root area of the central incisors should be done. If on the X-rays in the anterior part of the median palatal seam between the roots of the upper central incisors reveal a narrow bend, evidence of the absence of the bone tissue, this is a sign of interlocking the fibers of the frenulum of the upper lip into the median palatal suture that determines the diastema. In such cases, it is necessary to make plastic of upper lip frenulum. In the process of surgical intervention, it is not enough crosswise cut the frenulum. It is necessary to excise its fibers within in middle palatal seam. As a rule, the diastema can be completely eliminated before surgery interference. However, if the gap is large and the frenulum fibers have significant thickness, complete closure of the gap before the surgical interference may not be possible. In this case, the gap is closed at least partially and the orthodontic movement of the teeth to meet each other should be resumed immediately after frenuloplasty. In this case, healing occurs in the absence of a gap, and the resultant scar tissue stabilizes the teeth in the correct position and does not create obstacle for the final closure of the diastema. The plastic of the frenulum of the upper lip can be performed by various methods. Depending on the structure of the frenulum, the following techniques are used: frenotomy, dissection of the frenulum of the upper lip; frenectomy, removal of frenulum of the upper lip; frenuloplasty, movement of the attachment side frenulum of the upper lip. In some cases, to accelerate the orthodontic treatment, compact osteotomy in this area is done in addition. It should be noted that in the treatment of diastema, it is recommended that plastic of frenulum of the upper lip after the closure of the gap between the central incisors of the upper jaw. Thus, they prevent relapse of pathology, the cause of which is often keloid scars formed after plastic surgery of the frenulum of the upper lip can be. Plastic surgery of the frenulum of the lower lip and the vestibular of the oral cavity. The main indicators for plastic of the lower lip frenulum are chronic localized gingivitis, recession of the gums in the region of the lower incisors and periodontal diseases. The reason for the above-mentioned processes is the attachment of the frenulum of the lower lip close to the top of interincisors papilla with the shallow vestibulum of the oral cavity less than 5 millimeters. At cases of incorrect attachment of the frenulum when pulling the lower lip, the interdental gingival papilla exfoliates from the necks of the lower central incisors. Correction of the vestibulum of oral cavity and frenulum of the lower lip is often performed in one stage. The main task to orthodontists is providing the patient with a plan for vestibulum formation. Plastics of the frenulum of the tongue. The shortened frenulum of the tongue slows down the growth of the lower jaw and leads to negative inclination of the anterior lower teeth, can cause periodontal diseases, in particular gingivitis and gum recession in the area of the lower incisors. Elimination of the case in the form of a shortened frenulum of the tongue greatly contributes to the acceleration of orthodontic treatment and helps to avoid relapse. White frenulum is operated by moving quarter triangular flaps. After the dissection of the frenulum in young children, the muscles of the tongue retract. In older age, it is more difficult to overcome ingrained habits. After plastly of the frenulum of the tongue, many children cannot lift the tongue tip by themselves, even though the mechanical obstacle is eliminated. Therefore, after performing this operation, children are recommended to carry out myotherapy. Trainings with logopedists contribute to eliminate speech disorders. Next, surgical exposure of the crown of the tooth delighted in eruption. In the thickness of the alveolar process, after the expiration of the optimal teething remains the teeth that have run out or end formation of roots. Central incisors, canines, and second premolars occur unerupted more often than others. Treatment of unerupted permanent teeth is complex and conditionally divided into two stages. At the third stage, surgical exposure of tooth crown, excise bone in the direction of tooth traction. On second stage, fixation of bracket or a hook on the tooth for the subsequent extension it with the help of the orthodontic apparatus. Surgical exposure of tooth crown combined with compact osteotomy reduce the total time of orthodontic treatment. Before the operation, it is necessary to assess the presence of a place in the dentition for moving tooth. If it is not enough, you need to solve the problem and create the necessary space by moving adjacent teeth, expanding the dentition, or removing individual teeth. If there is an obstacle on the way of tooth movement, it should be eliminated So, for example, first remove supernumerary teeth, and after 2 or 4 months, during the repeated operations, exposure, the crown of the tooth delayed in eruption. Hot method, serial sequential removal of individual teeth or their groups. Hotz named his method management of teething by extraction. For this method of treatment, the following conditions are needed. First, absence of skeletal forms of the alveolar anomalies, the neutral ratio of the jaws, normal incisive overlap, significant lack of space in the dentition for 10 millimeters or more. This method includes the following activities. First, extraction of primary canines with a lack of space for the lateral incisors. Second step, extraction of the first primary molars when buds of first premolars are nearby. Third, message of the alveolar process in the area of the first premolar, but to accelerate its eruption. And next, extraction of the first permanent premolars, permanent canines erupt and set in the dentition. If there is significant space deficiency and all stages of secretional removable were carried out in a timely manner, this method can ensure complete closure of gaps and relatively normal placement of teeth without using any orthodontics apparatus. However, such a positive result is rare, and the vast majority of patients require treatment with non-removable equipment to ensure the correct location of the teeth occlusion and creating a parallelism of the teeth roots. With a neutral ratio of the dentition, a consistent instruction of teeth on the upper and lower jaws is indicated. With distal occlusion on upper jaw and patients with mesial occlusion on the lower jaw. Treatment using the method of sequential removal teeth starts after eruption of the upper and lower central and lateral incisors. That is in 7 to 9 years. The disadvantages of Hott's method is the need for long years supervision of patients. In these photos, you can see a patient with the labial segment crowding. Doctor used serial extraction of the teeth, initially deciduous canine, then deciduous molars and premolars. Treatment carried out without orthodontic appliance and was successful. Orthodontic indicators for the removal of permanent teeth. The first premolars are more often removed teeth. In some cases, other teeth, central or lateral incisors, canines, second premolars, the first permanent molars. Indications for the removal of teeth with narrowing of the dentition, measure displacement of the lateral teeth, inconsistency in the size of segments of dentition, as well as dimensions of apical bases of the jaws are determined by clinical examination, measuring of diagnostic dental models, and examining the lateral cephalometry of the facial skeleton. Study of diagnostic models of the jaws reveal a discrepancy in the width of the tooth crowns and their apical bases. Use the method of snagging. Then disorder of the ratio of segments of dental arches using Gerlach method. Measure displacement of the upper lateral teeth, the Schmut method. Analysis of survey data allows you to justify a decision about teeth removal and determine the teeth that are to be extracted. Orthodontic indications for the removal of teeth are divided into absolute and relative. Absolute orthodontic indications for the removal of teeth. Absolute macrodential. The sum of the crown widths of the four upper incisors equal to 35 millimeters and more, and for lower ones 28 millimeters and more. Relative individual macrodentia with a narrow face. The sum of measured distal dimensions of the upper incisors is 32 or 34 millimeters. The lower incisors 25 to 27 millimeters. A significant discrepancy between the sizes of primary molars and premolars on one or both jaws, and disocclusion of posterior teeth, requiring grinding of approximately the surfaces of the crowns of temporary canines and molars to provide mesial shift of the first permanent molars. Next, the mesial inclination of the butts of the canines and premolars from 35 degrees and more with respect of the median plane. Open bite combined with crowding anterior teeth and lack of space for them. Relative orthodontic indications for the removal of teeth. Early loss of primary teeth and subsequent shortening of dental arch due to the mesial displacement of the lateral teeth by 4 millimeters or more. Open bite combined with vertical type of jaws growth. Deep bite in combination with a horizontal type of jaw growth. Underdevelopment of the lower jaw. Excessive development of the upper jaw with distal ratio of dentition. Removal of separate teeth on the upper jaw is indicated. Underdevelopment of the upper jaw. Excessive development of the lower jaw with mesial bite. Sequential removal of separate teeth on the upper jaw is indicated. Treatment by removing individual teeth has drawbacks that manifest themselves in the of incorrect planing. These include tipping of the teeth located along the edges of the dentition defect, gaps in the dentition dependent, the incisive overlap. These photos illustrate a result of the treatment the patient with vestibular position of the upper canine. A treatment was successful. Goodbye, students. Thank you for your attention.